Okay. Assalamu alaikum. Masa al khair. Can everyone hear me? Okay. Thank you, Qadir. Assalamu alaikum. Sarah, thank you so much. Okay. أهلا. وعليكم السلام. مساء النور جميعا. Excellent. Okay. So we'll get started in a minute, but I see here that there are 75, 76. The number keeps increasing, which is good, registrants. And I want to thank you all for joining us today or this evening. Okay. Yes, I'm excited as well. I can't hear. Maybe can you try to please higher the volume on your device? Okay, the voice is clear. I don't know what this is. Okay, yeah. All right. Okay, so we're going to get started. What we're going to do is probably do an hour or so of lecture and then maybe take questions, and you feel free to ask any questions on the topic or something on patient safety that's related to the topic. Assalamu alaikum to the Saudi Patient Safety Center. Thank you so much for the invitation and for the opportunity to present such an important topic. I hope it's going to be fruitful for everyone. So let's get started. Bismillah ar-Rahman ar-Rahim, wa salatu wa salam ala ashraf al-mursaleen. My name is Hanan Idris. I am a faculty member at Johns Hopkins University. I'm also a faculty member at the Saudi Electronic University in Riyadh. I'm currently based in Riyadh. I go back and forth between Riyadh and the States. I also teach patient safety at Hopkins as well. So today's topic is the aftermath of medical errors and supporting second victims while ensuring a culture of safety. And I know that many of the hospitals and many of you, I'm seeing familiar names in the room, are working on maintaining and embracing a culture of safety in their organizations. And some are working at the ministry level, which is amazing. So I'm just seeing here in the chat box, there's still some people having issues with the sound. So I hope that that gets solved soon. So I'll try to keep a track on the comments. So if I do miss a comment, please, towards the end of the lecture, feel free to type a question away. So today's topic is on supporting second victims, and I'll talk to you a little bit about what second victims means. But before we get started, did anyone ever hear of the term second victim? If you did, please type yes, and so we can get an understanding of the knowledge that's in the room. Okay. I see there's 94 participants now. Okay, excellent. Excellent. Yes, okay. Okay, so it's good to know that some of you are familiar with the concept. So what we're gonna do tonight is go deep into the topic and really try to understand what second victims are, what they're feeling, how can we embrace them in organizations, how can we support them, and you know, what other organizations are doing, and what are some international best practices. Okay, very good. I'm glad that people have heard about it. Okay. I'm not sure if the slide went through, but do you see the title, The Story of Kimberly Hyatt, just so that we're all on the same page? Yes? Okay, excellent. Has anyone heard of Kimberly Hyatt before? So, okay, good, yes. I see Sophia. Thank you for joining us, Sophia. So Kimberly Hyatt was a nurse for over 20 years, and she was working in Seattle Children's Hospital. So it's very clear that she's very experienced, she's dedicated to her job, dedicated to taking care of patients, and not only any patients, but pediatric patients. Unfortunately, on September 2010, Kimberly was involved in a medication error, and it was on a 5-month-old child. Unfortunately, that 5-month-old child died due to an overdose of calcium chloride. Unfortunately, Kimberly was dismissed from her job. Okay? Unfortunately. And many of us have probably heard similar stories. So when something like this happens in healthcare, we tend to always blame the individual who's involved. We tend to not give them the opportunity to share their side of the story. So Kimberly was dismissed from her job rather than being invited to make sure that this doesn't happen again. She wasn't given the opportunity to share her experiences. What are some of the challenges? What led to this error? What could have potentially led to this error? Because it will happen again, unfortunately, at some point, right? Medication errors are very common, we all know, as healthcare providers, and the idea is you want to bring in your healthcare providers to give that type of feedback. So what we don't do sometimes in healthcare is we don't really ask about the doctor who wrote the order, because maybe the error happened in that process. What about the pharmacist that approved the order? That could be also a challenge. And what about the process or the system that set them up? Because we all know, working in healthcare, every system is designed to get the results that it gets. So if you have highly qualified healthcare providers, very educated, very experienced, and they're working in systems that are not so much experienced and automatic, then unfortunately you at some point will have an error. And unfortunately, in this case, this led to a death. And sometimes it could lead to a near miss. It could reach the patient but not harm the patient. So, you know, one of the things that we have to think about is, you know, after an error happens, what do we do? So yes, we will talk about guilt feelings. We'll talk about the sharp end as well. Thank you for your comments. So 10 months after the event, so if you remember, it happened in September 2010, 10 months later, unfortunately, Kimberly Hyatt commits suicide. And these are some newspaper clippings from that time. And you can see the headlines anywhere from nurse's suicide follows tragedy, so the tragedy of the this child's death. Devastated nurse committed suicide after she accidentally gave baby fatal overdose. Nurse's suicide highlights twin tragedies of medical errors. So the twin tragedies are the death of the child as well as the unfortunate suicide of Kimberly. So during this talk, we're going to go through 4 main objectives. The first one is to describe the second victim concept and its impact on patient care, to list the objectives and goals of the Johns Hopkins RISE program, which is a second victim support program. That's how one organization is handling this issue. To review study results on assessing the need for organizational second victim support in acute care hospitals in Maryland. And then to take a look at international best practices and give recommendations for yourselves and for your leaders to follow and to implement when you go back to your institutions. So I asked the question if anyone knew what the concept of second victims was, and most of you said yes. And there were a couple of people, I think, who said they haven't heard of the concept. So what we'll do is we'll go over the definition. So the idea is when a medical error or an unfortunate patient-related event happens, the first victim is usually the patient and the family. Unfortunately, the second victim is usually neglected. And the second victim is the healthcare provider or providers who are involved in the event, right? They were taking care of the patient. They were either taking care of the family, either they gave medication, maybe they were the primary care physician, the primary nurse, the pharmacist, etc. And this term was coined back in 2000 by Dr. Albert Wu, who is now at Hopkins. He's a full professor and doing internal medicine as well. And he wrote an article about his experience being an intern. This was back in 2000. And today we're April 2019, and we're still talking about the topic, and some of us are yet to be introduced to this. So I think there's a long way for us to go. Second victims, unfortunately, feel personally responsible for the outcome. They feel that they've failed the patient. Sometimes they second guess their clinical skills and their knowledge, or they don't feel confident enough to provide care. And some of the signs and symptoms are related to post-traumatic stress disorder. And I'll talk a little bit about that on the next slide. But the idea is that some people go through physical challenges, psychological distress, emotional responses can be an option, and then unfortunately impaired performance. And we don't really want to see that happen in healthcare, but unfortunately it does. The signs and symptoms of second victim, they can either be short-term or long-term. And unfortunately, we all respond differently, and we all know, each one of us knows ourselves really well. So we respond differently. Some people have short-term anger. They can experience guilt. Somebody said guilt earlier. Sleep disturbances, social avoidance. And then, of course, there are long-term that happen over the course of a few weeks, maybe to a few months, and some even a few years. And I'll talk a little bit about, there was a study that was done in Italy that looked at the long-term effects of healthcare providers. And I'll talk a little bit about that later in the talk. So long-term symptoms can include anywhere from avoidance, emotional numbing. You see the same thing happen over and over again and there's no reaction. Withdrawal and depression, social functioning is impaired, etc., etc. And there are also burnout symptoms. So anything from procrastination, chronic fatigue, cynicism, tardiness, pessimism, diminished future outlook, and loss of life satisfaction. So sometimes you feel that you're just coming to work for the sake of coming to work. There's no satisfaction in your work. You're very numb. So everyone feels something different after a medical error, and people react differently to this. So the error, unfortunately, there's an impact on not only second victims, as I mentioned earlier, but it also has an impact on the organization. So an impact on the individual, we talked a little bit about the PTSD symptoms that happen over 3 months. And then there are acute stress reactions that can take up to 1 month. So these are short-term. If you remember, the short-term were listed on the left-hand side, and the long-term were listed on the right-hand side of the list. There's an impact on the organization and the healthcare team because you start to lose trust between your coworkers. And then unfortunately, management and treatment of psychological care can also impact the work as well. And I'll talk a little bit about the continuum of care later on in the slides. So how common is this issue? So there have been studies that looked at the prevalence of second victims, but unfortunately, there hasn't been a very comprehensive study that really addresses the percentage or the prevalence of second victims. So if you look here, I just extracted maybe 4 studies or so. There are a few other ones, but these are some of the earlier studies that looked at the prevalence. So it goes anywhere from 10.4% up to 50%. So that's a large range. So for those of us who are working in statistics, we know that there's a large range, and the idea is that we want to come to a shorter range as close as possible. You can see here on the table that there are different populations that were included in these studies, in the different studies, and each one had a different scope. So they describe feelings and symptoms. For example, in study 1, there were some errors that affected healthcare providers in the past 6 months. Some of these talk about anxiety, depression, etc., challenge with and the ability to perform on their job. So I'm looking also at the comments here, and unfortunately some people are having trouble with the network. So I hope this lecture is recorded, and would be happy to share the slides as well. And also someone else mentioned nurses and doctors. Of course, they're affected, and there are also other healthcare providers that we tend to overlook. And as well as work overload, of course, that's also a challenge. So there are limited studies on second victims. And, I gave a talk, and I'll talk to you a little bit about my experience, but I gave several talks in Saudi Arabia. And I really hope that we could do either a national study or some sort of organizational pilot so we can, map this work. Because most of the studies have been done in Switzerland, they've been done in Belgium, Denmark, the UK, the US, Sweden, Italy, and other countries as well. I don't think, to my knowledge, we have something in the Middle East, so it would be nice to start a project on that. So if anyone's interested, I will include my contact details at the end as well. So there are also limited studies on second victims in terms of descriptions of organizational support programs. There's little documentations of the steps involved in their development. So many people I've talked to, they said, we're interested in supporting our second victims, but we just don't know how to do it. Can you share the process with us? So I'll talk a little bit about an overview. And then, of course, there are also limited resources for evaluating the feasibility of these programs. So even if you have a second victim support program, there are sometimes some challenges with understanding is it really working well, and what is the impact? What is your return on investment? So we can talk a little bit about the statistics, Marwa. There's a question here about adverse events and statistics. Of course, we can address this towards the end, if you can kindly remind me as well. And depending on the severity of the event, thank you, Hiba. That's very true, and we'll talk a little bit about that, of course. We're moving to the natural history of the second victim. So of course, there's always an initial response to the incident. Some people are shocked, they don't know what to say, they don't know what to do. Then there's always a peer response, right? So it's always what your colleagues are thinking, maybe also what your boss is thinking. And then there's an investigation, so risk management gets involved, there's leadership gets involved depending on the severity of the event, quality and patient safety departments as well get involved. And then finally, there's always a complaint system or a malpractice suit, depending on which country you're in. But the idea is that it doesn't just stick with the second victim and the patients. There's a whole range of people who are involved in an unfortunate event. And sometimes, we're doing better as individuals. We can manage our emotions. We've gone through stress. We either, relieve our stress through exercise. Some of us do other things, maybe spend time with family, maybe go see someone. So even if we're, as individuals, feeling better, sometimes we're getting thrown under the bus. And what does that mean? Maybe we're being blamed by our colleagues. Maybe there's good disclosure to the patient and the family, but there's maybe a poor follow-through, which has negative impacts, of course. Someone's mentioning here there's a blame culture, Rosalia, of course. And then there's also challenges at the expense of the healthcare worker, So even if you're, as an individual, trying to change and trying to support yourself, there's always these effects that happen on the units and maybe within the organization. So a dear friend and colleague of mine, Frank Federico, who's a VP at IHI, both of us, we wrote an editorial in the BMJ, and the idea was that we need, as an organization, as countries, as healthcare leaders, we need to support clinicians after medical errors, because unfortunately we're seeing many, many challenges. People are either leaving their work, people are leaving the profession, they're going into administrative jobs, and unfortunately in many cases, or in some cases, people commit suicide, as we've heard earlier with Kimberly's story. So we want to limit as much as possible these negative effects that happen because we understand that healthcare providers go into healthcare to save lives, they go in to protect patients, they go in to support patients. So the idea is not that they're intentionally harming patients. And so the purpose of this editorial was to really draw attention and call leaders to develop programs, to look at best practices, and collectively find solutions to supporting second victims in the workplace. Okay. Organizations that care for the caregiver. So these are just some, and there are a few that came up probably later. But initially, we did a search and we looked at the medically induced trauma support services. So this organization supports both providers and patients. They have a hotline and you can call. It's free of charge, I believe. And it started in Boston, and it started by Linda Kenny, who's also a dear friend and colleague of mine, and she started this organization and partnered with her healthcare provider after she experienced a medical error. So she was the victim of a medical error, and she partnered with the second victim to really help other organizations, because, you know, when she was in that unfortunate event, it was really challenging to find a support system from the healthcare system, from the healthcare entity. There's University of Missouri that have a very well-established program. It's called the 4U program. We'll talk a little bit about it. Kaiser Permanente also has a program. Boston Children's Hospital at the Office of Clinician Support. Dr. Joe Shapiro, I believe, leads this effort at Brigham and Women's Hospital. So she looks at the center, or oversees the Center for Professionalism and Peer Support. So they do a little bit of both. And then there's a program at Johns Hopkins Hospital, which is the RISE program, and I'll talk to you a little bit about that as well. But the idea is that there's no one program that fits all, so we need to understand what works best for our organization, and I'll talk a little bit about that as well. Then there's different types of support for psychological trauma. We'll talk about the psychological first aid, and we'll talk about rapid psychological first aid. There's also a concept called critical incident stress management. So if any of you are working in emergency response, I'm sure you've heard of this. It's called CISM. And then there are support programs specifically for the military. So if any of you are working in military hospitals, maybe some of the responders to maybe natural disasters or to war zones, they probably go through this type of training. Okay, so we'll go into looking at the concept of supporting second victims at Johns Hopkins Hospital. So this is just one case study. Dr. Wu and myself, and there was a great team, Lori Payne and others, who have started looking at this program in 2010. And I'm happy to say that it's still expanding. Back in, until in 2009, it's expanding. We're learning a lot from other organizations. We're implementing, we're changing programs, and we're also giving training. So I think the team was last here in Riyadh a few months ago, and they gave training at the National Guard Health Affairs on how to support second victims. And I think that many of you have attended, or some of you have attended. Employee health officers are also a good asset for second victim recovery. Sarah, yeah, thank you. That's very true. And Bin Dohri is support them for the claims before even confirmed to be an error. If you can please clarify that. But yeah, the idea is to really look at the system approach and not just identify the error and leave it as is. So if I'm not sure how many are familiar with the Johns Hopkins Hospital, but it is a 1,000 plus licensed bed located in the state of Maryland. It's an academic medical center, so we have many students going in. There's a lot of training, there's a lot of programs that are being offered there as well. So medical errors and adverse patient-related events are inevitable, of course. And so several events occurred at Hopkins, unfortunately, as with any institution, because no institution is perfect. And the hospital leadership took a great stance, and they decided that they wanted to create a second victim task force to establish an organizational support program. So initially we came and we said, okay, so we know that the intention is to support second victims. We want to support our healthcare providers, our staff, because if you take care of your staff, they'll take care of the patients. And so what we did was we developed a second victim task force. It was very multidisciplinary. We had physicians on there. We had nurses, of course. We had a psychiatrist. We had risk management. We had quality and patient safety. But the idea was anyone who would see a second victim after a medical error or relate to them at some point or interact with them, we wanted them to give us their perspective because we wanted to look at a multidisciplinary approach. And I think that's the trend now in healthcare. We want to look at multidisciplinary approaches, multidisciplinary perspectives, because many times when we're implementing policies or we're developing programs, it definitely affects the ecosystem. It doesn't just affect one type of provider. So as you're going back to your organizations and thinking about developing different programs, it's always good to have a multidisciplinary approach as well. Yes, so there is a comment here about we should support second victims by proper staffing, of course. You know, staff ratios are very important, and sometimes that can lead to burnout and errors, of course. We don't want to wait until an event happens, but events do happen and they will happen. You will not find an organization that doesn't have any errors. So it's always good to be proactive and also reactive at the same time. Ashjan is asking, is there any supportive program in Saudi hospitals? So I'll talk a little bit about that later on, of course. So going back to Hopkins, we have the infrastructure. What we did was we didn't know how to start. So we developed this task force and we said, okay, so what type of services do we have within the organization that can be very supportive to providers? So we did a little inventory, if you will, and we found that this list was very comprehensive in terms of different types of services that could maybe help second victims. So there are, of course, the patient safety and quality departments. We have risk management. We have an employee assistance program that really helps employees with their personal issues that affect their work or performance at work. There were also chaplain services, occupational health, and of course, human resources. However, there was no clear pathway to help second victims cope with their emotions. So each of these programs kind of touched, or each of these departments kind of touched on supporting second victims, but there wasn't any ownership. Okay, and yes, as someone's mentioning in the comments, it's very important to have leadership commitment, and I'll talk a little bit about that. Rueda is asking about second victim policy. We can definitely talk about that as well. There's another hospital that's working on this. Okay. All of the comments on staff support. So after we've developed this second victim task force, after we have looked at this inventory, we wanted to do an organizational assessment. Okay, so what does that mean? It means just creating a survey. And what we found was that in June 2010, at the second annual Johns Hopkins Patient Safety Summit, we presented the concept of second victims and we distributed surveys. We had 140 or so responses, which was really good. However, our results were very shocking because people said 2/3 of the individuals reported experiencing emotional distress following an unanticipated adverse events. So 2/3 is a huge number. And these are more likely to be experienced healthcare providers. There was more than half that had reached out to for support from a colleague or a friend. So that's also an important concept that we found. And then there's also the need for a peer support program. So these were generally the themes that we found, and we published this work. So after several meetings, after brainstorming sessions, etc., we've developed the RISE team, which is resiliency in stressful events. And the mission was to provide timely support to employees who encounter stressful patient-related events. And timely is very, very important. I'll talk a little bit about the importance of that. The objectives for this team was to increase awareness of the second victim phenomena. It was to provide multidisciplinary, so one-on-one support or group support in a non-judgmental environment. I mean, many times errors happen and it's not just one healthcare provider who's involved. Maybe it's a whole team. So we do that as well. And then we want to allow managers and employees to have access and to be aware of healthy coping strategies to promote well-being. And we also want to reassure and guide them to continue to thrive in their role. So we don't want to see any suicide attempts. We don't want to see people leaving the job, leaving the profession, because as we know already, there's already a shortage of healthcare providers. And you know, when there's good intention and smart people working to support patients, we want to make sure that they continue to thrive in their role. So what we've done was we looked at developing the program in different phases. So the first phase was to develop the RISE team, as I mentioned earlier. We wanted to recruit and train peer responders, and we'll talk a little bit about that, and launch a pilot. And then once the pilot becomes very established, we want to roll this out hospital-wide. So what happens when an event occurs? So this is a brief, very, very brief flowchart, but of course there are many details that are not listed here. But after the medical error happens, individuals, either the second victim, the manager who's on the unit, it can be legal, it can be a peer, they activate a RISE pager. And the RISE pager is available 24 hours. It's held by a RISE peer responder who's well-trained to receive the call. And what ends up happening is the peer responder agrees or meets with the second victim, either on the phone or in person. And the idea is that you want to discuss not necessarily the events that happened, but what made you uncomfortable about the aftermath of the error. What can the organization do to support you as an individual? Do you need time off? Do you need more awareness? Do you need the opportunity to share your experience? What can the organization do to help support you as a healthcare provider? Because we don't want people to be leaving the job, as I mentioned earlier. We don't want absenteeism. Or we don't want this to happen to the next patient, you know? So if you're numb, emotionally numb, it's highly likely that it will happen to the next patient if you don't manage your stress or emotional feelings afterwards. Okay, so what does RISE do? So RISE is very supportive and attentive conversation. They have that with the second victim. The idea is to facilitate resources within the hospital that might be helpful. So I mentioned earlier there was like an inventory of resources. There are also other types of resources. Maybe there's educational sessions. Some organizations offer you know, massage therapy that can be helpful to individuals. Everyone reacts to things differently. There could be gym membership, you know, so it depends on how you personally manage your stress, and everyone's different. So the idea is to provide 24-hour support, 24 hours, 7 days a week, because most errors, the literature will tell you, is that most errors happen after hours. Most errors happen when there's no managers around. Most errors happen on the weekends. And so the idea is to make it available and timely. And of course, we offer one-on-one or group support. What does RISE not do? RISE they're not a group of counselors. We're not psychiatrists. I think I got a message here that said the connection my connection was weak. Is it? Hear me now? Okay. Okay, I think people can hear me now. No sound? If someone can tell me they can hear me. Okay, good, wonderful. It's cutting, okay. I don't know. Okay, so I'll continue to speak until most of you mention that you can't hear me. So what does RISE not do? We're not a group of counselors or psychiatrists. Okay, good. So there was a okay, excellent. So we're not a group of counselors or psychiatrists, and we don't really investigate or go back. Thank you all. We don't really solve any problems, and we don't really fix employment problems. So the idea is to be an attentive listener, is to be a non-judgmental listener. And so what do these peer responders do when they get the call? They are trained in psychological first aid. So psychological first aid is similar to physical first aid, and I'll show you a table or a chart on that. But the idea is that we want to intervene early to address emotional distress. We also have peer responder meetings and educational sessions. We do a little bit of lectures, role play, video excerpts, handouts, narratives. But the idea is that you want to provide ongoing training, because many times what we do as healthcare providers, we're trained in one thing and then we don't keep up and we're not updated. So we want to know what works well. We want to know what doesn't work well. And the idea is to also do debriefings as well. So the idea of continuum of care, what we want to do is we want to look at the physical first aid, If you look at the bottom of this arrow, there's a physical first aid, there's basic life support, and then there's advanced life support, and then medicine and surgery. So many of us are very familiar with this diagram or this trajectory of providing physical first aid all the way to medicine and surgery, depending on who it is. So what psychological first aid does, it mirrors the same thing of physical first aid, but the idea is to stabilize psychological and behavioral functioning. You want to mitigate psychological distress and function. You want to facilitate the recovery, and you want to go back to the adaptive psychological and behavioral functioning. So there's a box around the green part for a reason, because what we do as RISE team, we want to put the Band-Aid on the situation, and then it's up to the second victim and the organization to escalate through crisis intervention, counseling, or psychotropic meds and therapy and psychotherapy. So it just depends. Okay. So I'm going to pause for a second and try to read some of the questions, because I know that there were some really good questions up here. So yes, KFH also has a similar program. We'd like to hear about your experience, maybe during the end of the talk as well. That would be nice, Hiba. OH staff should be certified to provide emotional support, of course. They're definitely involved. They were involved in our team as well. We need to think about supporting the first victim as well as the second victim, Fawzia, absolutely. So this is part of disclosure. And I think that's a huge topic for another day. Health education department, part of it can be part of it, of course, depends on your organization and how much you want to get others involved. Second victim support is a Sibahi requirement. Thank you, Tara. That's very helpful information. So it's good to know. Any role for chaplain services in Saudi, of course. There's always an opportunity. And if there isn't a role model doing this or a role model organization that involves chaplain services, there's always an opportunity for you to start something as well. Samia, I'm happy to share the questionnaire and the survey, of course. We can definitely discuss that. Okay. We don't really have any surveys for the blood bank, Adil, but we do have a general survey, and I'm happy to share that as well. Okay, yep, someone else is also asking for the organizational survey. It's very popular. Does RISE help with the disclosure process? Not necessarily, because the disclosure is generally by patient. It's for patient, provider to patient. Right now we're talking mainly provider to organization support or provider to provider support. So the patient here is not necessarily involved, if you will. Okay. So again, there's another question about disclosure as well. Few questions about disclosure. Okay. All right, similar to the military support program. Yep. Of course, as I mentioned earlier, there were some military programs that were helpful. Is there any mandate policy for counseling for traumatized providers? So I think that would be a different topic, but there are, for example, I know that the Joint Commission in the US, they had recommended, and I think maybe they're in the process of probably requiring organizations to support second victims or implement a program. Can this be applied without just culture? That's definitely a question that I would love to address. But the idea is we need to have a supportive culture in order to have second victim support, because without a support culture, this concept won't work, right? Because the idea is that you want to have attentive listeners, you want to have a supportive community, you want to have a blame-free environment, you really want to address the issue. Okay? For non-Saudi, I think all hospitals should have this. I think it should be an organizational program accessible to everyone who is providing care, regardless of the background. Of course, it's related to safety of culture, and we can definitely talk about that. I'd be happy to give another talk on the culture of safety in general, and then talk a little bit about the impact of second victim, and of course others as well, when we're looking at other issues. Okay. Thank you for the informative presentations. 19 years later, we are talking about, let's abandon the term. Yeah, some people will say we can abandon the term, and of course it's it's a discussion that we should have, of course, and we can talk about that towards the end. Okay, so some people are very emotional, it says here, healthcare workers. Okay. Would you consider supporting staff who investigate these adverse events? Of course. They're neither the first, yeah, they're not the first victims or the second victims. Some people call them the third victims. So the third victims are either the risk managers, or maybe the hospital leaders, or maybe the organizations. They're not necessarily directly involved in the event, but they have the aftermath of supporting that second victim. So that's definitely, that was definitely mentioned in a couple of articles that I have read on second victim support. Medical legal liability, we can talk a little bit about that, but I think it's very dependent on which organization you're working for and which country you're in. So for example, in the state, we house this program under the patient safety umbrella. So it was a patient safety organization that was protected if anything was to rise in court. So that's something that we need to address here in Saudi before we go in deep and addressing second victim support programs. Organizations have legal and moral responsibility as well, of course. Support services are fundamental, absolutely. Okay. So when they looked at the financial impact of implementing RISE, there was an article that looked at this. So this is, take this with a grain of salt, but the idea was to put a number around the issue. Of course, it can be done very, very detailed, and I think maybe that's something we can come up with. But the idea was that the objective is to conduct an economic evaluation on cost-benefit of RISE for nursing staff who used the program between 2015 and 2016. So what they looked at was the cost of running RISE, nurse turnover, nurse time off, data on costs and probabilities of quitting or taking time off, with or without the RISE program, and then the net monetary benefit and budget impact of RISE. Of course, there's always other numbers that we could use, but these are the numbers that could be published. The results was that there was a net benefit, monetary benefit, savings of $22,576 per nurse who initiated a RISE call. So you could think about it per physician. You could think about it as per pharmacist, etc. And of course, salary information is calculated into that. Of course, salary information is calculated in that time, experience as well. But $22,000 is a lot. And so what they found was that the budget impact analysis revealed that a hospital could save around 1.81 million each year just from having a RISE program, right? So this is back to a comment earlier, someone mentioned we need to be proactive rather than reactive. So having this program will prevent you, generally, that's what it says, will prevent you from having more medical errors from happening, more adverse events happening. So you want to capture that and prevent it. So even though it looks like it's a reactive program, it can be seen as a proactive program as well. Okay. So what we're going to do is we're going to take a look at some of the international experiences. Of course, there are others. There are a few organizations that have worked on this topic, but they haven't really published anything on it. So I will just show you some of the work that's being done in the literature. So what we did was we looked at assessing the need for second victim support, and we did a survey or interviews for patient safety leaders in acute care hospitals in Maryland. So we interviewed 43 patient safety representatives from 38 acute hospitals in Maryland. We did semi-structured interviews, developed the questions, etc. And we looked at descriptive statistics that were generated for hospital and participant characteristics. And we published this work as well. You'll find the references in the next couple of slides. We had a response rate which was really, really positive, 83%. So that was really good. So we published in 2 different papers. The first paper was titled "Hospitals Support Second Victims, Safety Leaders." So we asked them, we asked these individuals to describe the extent to which organizational support for second victims is perceived as desirable, and to identify existing second victim programs, All of the hospitals said that they offered employee assistance programs, for example, but there were gaps in the services. For example, they weren't timely, they weren't supportive. So even though there are some programs that support second victims here and there isn't something specific for second victims that's useful or effective. There weren't any valid measures in place to assess the effectiveness of these services. So many times as healthcare providers and leaders, we develop programs, we implement, we take a lot of time off, we take a lot of money to invest, and then we want to look at the return on investment, but it's really hard to assess that. How do you assess something like this? Participants identified a need for peer support. So that was kind of a very important factor that we kept in mind. And we also found that among the 38 hospitals that were included in the study, only 6 offered a second victim support program. And I believe one hospital shared a second victim program with another hospital. So there was maybe probably a total of 5 programs. The other paper was, does one size fit all? And what we wanted to find out was, is the second victim problem prevalent? Is it widespread? Or is it just something that happens at Hopkins? We wanted to determine the availability of emotional support services, and we wanted to look at the need for organizational support programs. It's really interesting to find that all participants, all of them, reported that they and their executives were aware of the concept. All participants believe that hospitals should offer organizational support, and unfortunately, there continues to be a huge stigma, negative, of course, associated with speaking up and accessing support if it was there. So that goes back to a lot of the comments on safety culture. So, if you don't have a strong safety culture and supportive safety culture, then your second victim program and your employees won't be satisfied, and they won't be comfortable with working in your institution. They'll go elsewhere for sure. So I'll take you to Belgium. Belgium, there was an article that was published. They're doing a lot of work as well, but they wanted to look at the type of most memorable patient safety incidents. So there are things that happen, with infrastructure that affect patient safety. There are things that happen with staff behavior, patient accidents like falls, infections, etc., medication errors. And so what they found was that the most common or most frequent type of patient safety incident that affected second victims was medication errors or IV fluids. And we heard about that with Kimberly's story earlier in the presentation. And then followed by clinical processes and procedures. So that's very important. So if any of you are drafting clinical processes or procedures or looking at flow charts in your organizations and plans of care, it's very, very important to be very clear when you're writing these up, and to make very multidisciplinary so that everyone has input regardless of their position in the organization. And then the third most common one was staff or patient behavior. So these are the most frequent issues or the memorable types of patient safety incidents that happen in the organization. So let me pause here for a second to see if there's any more comments. The way the investigation, so Ijlal is asking, we need a Ministry of Health guidelines or a policy of second victim management as one procedure of reporting policy. Absolutely, that would be helpful to have. Raghda is asking, the way that investigation is held is very important. The way the staff is being questioned. We should have strict guidelines on this, of course, and training as well. Thank you, Abdullah. I'm glad to see that it was helpful. Aldrin is asking, how would you address gross negligence in relation to second victims? So we could talk a little bit about that. But the idea is that this comes complementary to a lot of the programs that are already existing. So this doesn't really, it doesn't really replace any program. So there should be disclosure involved. There should be disclosure process. There should be handling of the error, looking at the error, investigating the error. That should all happen. But second victim support programs should complement all these services. Confidentiality. Unfortunately, once an event happens, the names of the staff involved will be known to staff in different departments. This negativity impacts the second victim. Of course, confidentiality is very, very huge, and there's still stigma attached to accessing support. But there was a huge stigma when we started reporting medical errors, if we remember those days. We started to report medical errors and people didn't want to report anything. But now it just becomes very common. And if you go into an institution and they don't report errors, then there's something wrong with them. So I think or the whole process. So I think there's definitely a challenge maybe at the beginning, but becomes practice later on. I think also, even when we're looking at infection control precautions and barriers, if we look at the history, people weren't working on these, and over time it became common to use isolation procedures on certain types of patients, etc. Okay. Sada's saying, I hope that the Saudi Patient Safety Center can adopt any program support in the second victim and mandate to all hospitals. Yeah, we can definitely do something like this that would complement a lot of the work. Okay. All right. So let's look at the study that was done in Italy. This is very interesting because what they did was they looked at the pathway of recovery after an adverse event and looked at the elapsed time between the event and the outbreak of the first symptom. If you look at the different columns, so they looked and interviewed. Hello, can people hear me now? I think there was an issue with, okay, excellent. All right, thank you. Apologies for this. I don't know why. Okay, so I'll take you to Italy. So there was a study done on the pathway of recovery after adverse events, and what they did was they interviewed 33 individuals, and they're all healthcare providers. If you look at the second column, this indicates the date of the event. So there's a range of dates. Thank you so much. There's a range of dates that have that are listed here. So some people ended up being involved in events that happened back in, let's say, 2007, some 2006, some are 2001. So, I mean, that's a pretty long time ago. The third column looks at the outbreak of symptoms. So when did this outbreak of physical symptoms happen? Immediately. Everyone said it was immediate, right? So that also tells us something. The fourth column says the outbreak of the psychological symptoms. When does that happen? So some said immediately, some say after a couple days, some people say after 1 day. That varies, so that's variable. And how long did these psychosocial symptoms happen? Some people said 2 months. And unfortunately, some people said that they're still happening. So can you imagine, if you look at interviewer or interview number 2, the event happened back in July 2005. There was an immediate physical symptom. And then immediately there was an outbreak of psychosocial symptoms. And unfortunately, until today, so this article was published when? 2016, so it was 3 years ago, it's still present. All right, so that's like over 10 years, and they're still thinking about that. Unfortunately, the very last column tells you what the patient outcome was, and in this case, there was death. But if you look at this entire list here, I mean, you know, some people had symptoms for 1 month, some people had symptoms for 4 months, 8 months, 1 year. But I mean, regardless of the number, I mean, can you imagine coming into work every day and that event is still on your mind from the day before? Now that's challenging. That's unfortunate. So the pathway to recovery, what they did was they asked different questions and they said, what did you do to face your needs? Most people said that they wanted to be understood. What are your suggestions to help a colleague that lived a similar event? Most people said that they wanted to talk to a profession or psychologist. That's 88%. What are the support and what are the support supplied in the atmosphere after an unexpected event in your job happened? So most people said that there was no type of support and there was an unfriendly atmosphere. So many people talked a little bit about safety cultures. That's very important. You could see that, and I mean, even in Italy, it's happening. What could you suggest as support or orientation systems for second victims? So most people said to have a psychological counseling service supplied by the corporation or the organization, but out of the same that respects the privacy. So something that's involved in the hospital, but not necessarily reports to, for example, the patient safety quality team or to the risk management team. Something separate, but still within the organization. So these are some recommendations from these 33 interviewees. Of course, there are many other recommendations, and so we just need to be mindful of this. Rosalia is saying that the healthcare setting is always patient-centered, so it's nice we can also have the healthcare provider, okay, involved in mental health practices, of course. Okay. The 4U program is very established at University of Missouri. Of course, there are 3 tiers of types of support that can happen. So what they did was, you know, they wanted to involve everyone in the organization and not just hand select peer responders. So their tier 1 training was at the very local level. So it was providing support to everyone, providing training to everyone. The second tier was they wanted to have more trained peer responders and patient safety and risk management resources as well. And then the last tier was expedited referral network. So these are more specialized services, and I won't go into too much detail, but that would be helpful to understand that, you know, not everyone is trained the same, and of course you're going to have different tiers, you're going to have different leaders lead this team within your organization. Okay. Of course, we want it to be person-centered. We want it to be patient-centered, of course. The other study that was done in Denmark, I had the opportunity to be invited to Odense University Hospital, which is in the southern part, and it was very wonderful experience because the team over there is very supportive of their colleagues, and what they wanted to do is involve the Department of OBGYN and the Department of Oncology to start a second victim program. They called it the Buddy Study. So in their program, they have identified a peer who will always be there to support you, and you can so it's kind of like, you know, you have a buddy at work, you have someone to help support you, and someone to be there for you, and someone to really identify, because sometimes, you know, when we're going through these events, we don't realize that we're traumatized, but maybe somebody else who knows us really well sees these effects. So that's also important to think about. This slide is very important because we want to look at a national approach to supporting second victims. The Saudi Patient Safety Center actually held a workshop back in Jeddah 2018. It was excellent. I loved that workshop because it really involved not only healthcare providers, but it brought in legal, it brought in patients as well. There was a very multidisciplinary approach, very well received, and it was very interactive. And so there are a lot of great ideas that came out of this. Some people mentioned that it would be helpful to have a national policy. And I think in some of the comments earlier today, someone mentioned, the Ministry of Health should be leading something like this. And of course, you want to look at different organizations. So that's also an approach as well. Because many of our healthcare providers sometimes do locums at different organizations. And so you want to make sure that that service or that type of care to healthcare providers is consistent across organizations. So since I gave that talk back in 2018, there were several organizations in the kingdom that have, really taken the lead on this, and I wanted to recognize them. So the National Guard Health Affairs offered a workshop through Hopkins, and it was on supporting second victims. The King Abdulaziz Hospital also gave me the opportunity to present, I think it was last month. So they mentioned that their leadership is very, very keen on doing this, and they're actually drafting or have drafted second victim policies to implement in their organization. So I want to congratulate them for taking that lead. And King Fahd Specialist Hospital in Dammam is also working on developing some type of program. So I also want to congratulate them as well on their efforts. So someone's asking, I don't think that there's a national policy on this yet, but if there's a group that would be interested, we can definitely coordinate maybe through the Saudi Patient Safety Center. I think it would be helpful. Okay, so we want to ensure that a culture of safety is very, very established for second victims. And if we can be reminded of what safety culture is, it's really, really important. But I won't go through this definition. I think many of us know what safety culture is. It's really just a group of values and attitudes and perceptions, and really how things are being done in this organization or in any organization. And so when you have a positive safety culture, this is based generally on clear communication, transparent communication, and it's based on mutual trust, shared perceptions, making the patient the center of care, not blaming others, not having punitive responses, and on the right-hand column here, we have a non-punitive response to error is really the extent to which staff are not being blamed when a patient is harmed, and they're basically being treated fairly when they make mistakes, and they feel safe to report many of these mistakes as well. A non-punitive response to error is critical to the success of second victim intervention program. So somebody mentioned earlier, how do you do this with a safety culture? If you don't have a strong safety culture, and many of us can measure these through HSOP surveys and other types of surveys, or many surveys, and we can give a talk, or I'd be happy to give a talk on how to measure safety culture and what do you do with your results after you get them. Because it's not a matter of getting a high response rate, it's not a matter of getting positive results. You really have to understand the underlying messages that your staff are telling you. And if it's a confidential and anonymous survey, you really have to listen to what the staff are saying, because sometimes they won't verbalize these issues, and sometimes we tend to overlook them. And we all know with the Swiss cheese model, when one defect happens, another defect happens, another defect happens, and we tend to overlook them, then unfortunately that affects the patient. So we want to prevent this from happening. So how can your organization participate? Now that I shared with you the concept, the feelings that come around this, we talked a little bit about Johns Hopkins program, the RISE program. I shared with you some of the challenges. I shared with you some of the international best practices as well. So now what we can do is take these concepts and see how our organization can participate. So the first thing we want to do is we want to acknowledge the problem of the second victim, right? Some people are still in denial that doesn't happen. So we want to acknowledge the problem that it's there. When errors happen, we want to encourage staff to be involved in system changes that will mitigate future errors. So unfortunately, in Kimberly's case, she didn't have that opportunity to participate. She was dismissed from her job, unfortunately. We want to hold debriefings and offer staff training and formal organizational support. So some of this work is actually going on in your organization. We do have people who support each other, but it's very informal. And if you're part of a network within your organization that really supports each other, then that's great. It's wonderful. And I would encourage you to continue to use this. But many people don't have access to that. So, as part of supporting staff, it's good for organizations to develop this type of program so it's accessible to everyone. And then finally, to develop multidisciplinary second victim support programs that align with existing organizational infrastructure. And you want to make sure that you communicate this and collaborate with other institutions and maybe form a coalition, perhaps, or something along those lines. Okay. Lessons learned. So the Journal on Patient Safety and Quality is published by the Joint Commission. And what they do is that they mentioned that they put together a toolkit, to be honest with you. And they looked at different toolkits from different organizations. And I didn't list them all in here, but you can access the article. And the idea is that, they wanted to look at internal culture of safety. So somebody mentioned that earlier. So there are different types of references you can access. There's leadership buy-in, there's organizational awareness. There's so many there's policies and procedures. So there are so many different policies that we can access and in order to develop our second victim program. But one of the mistakes or one of the challenges is that we tend to copy and paste programs from other institutions, and we all know that we need to adapt it to our local culture, we need to adapt it to our organizational culture, we need to adapt it so that it fits in with the ministry's vision, so that it fits in with the accreditation organizations, and that it really does have a benefit. So I want us to be mindful, so when we're going through these tools, it's very important to understand that we can pick up the best practices and then develop something on our own. Okay. So challenges to implementing a second victim program. Of course, there's still a stigma attached to seeking support. There's leadership support. There's scarce resources and sustainability of services. That's also a challenge. There's legal considerations, liability and accountability. And then there are also social perceptions of second victim support. So those are many challenges that some of us have probably seen or will be seeing. So that's something that we should keep in mind. Okay, so we're almost done here, and we'll open for questions. But the idea is that we want to be mindful, and if we don't have resources, because in healthcare we don't really have many resources to begin with, and we're asked to do more with less. So one thing that we could do is maybe print something like this out, and this is published, so you can feel free to print it, and some organizations or some staff put it on the back of their badges, just as a reminder. But there's two columns here. There's things to say to second victims after medical error happens, so supportive things to say. And then there are things not to say. So things to say are, something along the lines of, are you okay? You've had a tough break, thank you for sharing this with me. What are you doing to cope, etc. These things happen to all of us, etc. Things not to say is, okay, I think I'm back now. I'm not sure why the connection keeps going back and forth. I'm actually in a very good area. So I'm not sure if there's sound now, if anyone can hear me. Okay, there's sound. Okay, good. Good. We're almost done here. So there's things to say, and then there's things not to say. And so one of the things that we don't want to say is, didn't you realize what would happen? Or what were you thinking? I wouldn't have done that if I were you. You need to get over it. I mean, all of these sound very negative, right? And the worst thing is just not saying anything. That's the worst thing, because everybody's talking about the event, but no one's saying anything to you. So can you imagine being in that situation? It's very, very tough. So, one of the things that I want us to think about as we're taking all this information in, it's a lot of information, but for us to brainstorm. So, okay, I think the connection is lost again, or maybe we're back on. But what I want to do is maybe just share a few concluding comments. Can people hear me? I'm not sure if anyone can hear me, but the idea is what we want. Okay, good. So what we want to do is we want to take all this information, see what works and is relevant to the situation that we're in. You could either start with a small pilot, but you want to be very mindful of how you measure, who you get involved, because the worst thing that we could do is start a program and then it doesn't work or it has very negative effects. So it's very, very important to carefully roll these out, as has been done with many other programs that we have seen in the past, whether it's medical error reporting, whether it's disclosure processes, etc. And so, one of the things that we could do is to maybe develop some sort of coalition with the Saudi Patient Safety Center, and we have Sophia with us here to help send that message, of course, and perhaps we can discuss it during the next session. Okay, so maybe I'll hand over the mic to Sophia, or if anyone has any questions, I'd be happy to take them. So Ghadir is asking, from your experience, have you noticed that second victims are exclusive to a specific category of medical errors? So no, I think everyone reacts differently. So for example, a medical student will probably react differently to an event that happened, in comparison to someone who has 20 years of experience. And maybe someone will react to death maybe differently than they would react to a medication. Okay, I think the sound is back now. I apologize for the connection. I don't know how else to handle this, but I hope that it was helpful. I tried to pause in between. So I'm glad that the presentation was very helpful. Of course, you want to convince leadership to take in part, and they have to be convinced first, because if they're not, then it won't work. And I think that happens a lot with many of our patient safety and quality initiatives. If leadership is not on board, then they're not investing financial resources, they're not investing the time. And so it's really important for us to keep them involved very, very early on. Otherwise, it's just another concept that we want to implement and it doesn't work.
Hello?
Any preventive measures? Oh, hello. Hi, Sophia.
Hi there.
How are you?
I'm good. Can everybody hear me?
We can hear your dog.
I'm so sorry. My dog starts doing this once I start talking. I don't know why. I'm really apologizing for that. Take longer from everybody. I just really, really appreciate and thank you, Dr. Hanan, and everybody that it's been online since 8 p.m. It's amazing to see the interaction and the interest around this topic, and the fact that we have so many people looking forward to see the change. It does speaks volumes to us as the Saudi Patient Safety Center. For those of you that don't know me, I'm the manager for capacity building, and second victim, it's a topic within patient safety that is very important to us and that we are looking very close into. And in addition to the initiatives that Dr. Hanan Idris has mentioned already, I just would like to share that we are starting a national campaign on Safe Staff Saves Lives. And Dr. Hanan Idris part of our team, obviously, and we are pushing into having high-level stakeholders to look into this at the governmental level, and we are aiming actually to bring this internationally. Hopefully, as the Saudi Patient Safety Center and as a national entity that we are, we will be able to promote, to endorse, and to implement programs that do support patients through safe staff. We want to have a more proactive approach, other than, once we have a second victim, it means that the error has happened. So we want to have we want the approach to be more proactive and to do support and to have standards that do support our staff to make sure that the error doesn't happen, so we don't have second victims to have to deal with, hopefully. So I would like to really appreciate your time, Dr. Hanan, and everybody else that has been online. It is overwhelming, and I really appreciate everybody to be there.
Yeah, thank you so much, Sophia. I think that's it's very important, and I think we're all looking forward to the Save Lives initiative, and I think many of us would love to be participating in this as well. Would it be okay if I think there was maybe a couple of questions, and I want to make sure that
definitely.
people's questions are responded to.
Go ahead, Dr. Hanan. I just want to reply. There was
I think somebody mentioned RISE. They asked if RISE needs to have healthcare providers specifically. So it's good to have a multidisciplinary approach. So you want to have clinical staff for sure, 100%. But you can also include admin staff as well to help with coordinating, to help with processes, to help with bringing together the ideas. So you want to have a good mix of admin and clinical staff. Are there selection criteria for members of support teams? For sure there are. You want to have people who are non-judgmental, people who are very well known in the organization for being supportive. Okay, it cut off again, but I will try to summarize all the questions together. So you want to make sure that there's a multidisciplinary staff, both clinical and non-clinical, to help with moving the program forward. You want to make sure that you're taking care of your staff, of course, so that they can take care of the patients. And then is it purely psychological support? There's different types of support, and we can go into it in further detail. If you can contact me afterwards, of course, I'd be happy to share the information with you as well. Are there selection criteria for members? Of course, you want to have individuals who are leaders in the organization. They can be informal leaders, but they're very well known for being supportive to staff. They're non-judgmental, they listen attentively, and they can help solve issues as well. And then I think, okay, occupational health specialists should be part of the RISE team, of course. That's actually very, very important. What type of training to start a RISE team? So there's definitely psychological first aid, then there's different types of role play and lectures that can be offered, and we can talk a little bit about that later on. staff as well being important to be part of RISE, of course. Any preventive measures to reduce incidence or impact of second victims. When you have a strong safety culture, when it's open communication, mutual trust, opportunities to voice your concerns, and medical errors, when they're reported, they're actually implemented on and things are changing. That's one way, and that's the main way to reduce incidence and the impact of second victims. And the other part is to really just increase awareness. So anyway, so thank you so much, everyone, for your time. Thank you again to the Saudi Patient Safety Center. Thank you, Sophia and Dr. Abdelilah, for making this also a priority as well. Yes, I'm definitely happy to share my email with you. I believe it's on the screen. It's at the very last slide. I'm also on LinkedIn, so for those of you who are using social media, I'm happy to communicate with you through there. And then the initiative for supporting second victims should be through healthcare providers who have direct patient care. This is Sara's comment. Of course, definitely. So I think we're all looking forward to being involved with the Saudi Patient Safety Center initiatives. And I want to thank you so much for your time. I know that many of you, it's late in the evening, so I really appreciate you, logging in and taking the time to listen and to comment and to be actively involved. I think we've reached, it was like over 112 individuals or registrants. So that's actually very impressive. I'm very happy to see that. Okay, thank you so much for your time. Thanks everyone, and I hope you have a good evening.